and we get excellent flow and CSF signal suppression to have a better delineation of the vessel wall. So we do a coronal acquisition. So coronal acquisition provides us with adequate, craniocaudal coverage. And since the anteroposterior slab is only up to 4 to 5 centimeter, but this craniocaudal acquisition provides us with an adequate AP coverage as well. So we are able to visualize like the distal V3, V4 segments of the vertebral artery, basilar artery, and even like the P1, P2s, and distal cervical carotid, cavernous, supraclinoid carotids, M1, M2s, A1, A2s, and to a certain extent, distal cortical branches are also visualized. Okay, so this is our the extent of coverage. So if you look at this MIP images, so that's like as far as the anterior like scan goes, and this like as far as the posterior like the slice goes. Okay, and this is our craniocaudal coverage. Okay, and this is a 3D sequence, like isotropic sequence, and we can reformat this with sagittal and axial reformats or oblique reformats without losing the resolution. Okay, so this is like how our sequence looks like. So this is a non-contrast study. So you can see here, like on your first image, like the left upper corner. So you can see the carotid terminus on the left side, right? So nice bifurcation, M1, A1, and you have the supraclinoid carotid and the terminus here. Same thing on the right side, nice delineation of the vessel wall. Flow is completely suppressed and CSF is completely dark here. And you can see the basilar artery here, and you can also visualize the anterior inferior, like the cerebellar artery here, right? And these are the vertebral arteries. So this is the axial reformats showing you the kind of the axial images without loss of resolution and kind of nice crisp images of the vessels. Okay, so what's the advantage? Why do we do 3D technique? So main thing is like, we get thinner slices. So there is better contrast to noise ratio, better signal to noise ratio. You can delineate the vessel wall very well. And the coverage is kind of pretty adequate to assess most of the vessels. Okay. So, and other advantage is like, say like, if, as we do it on 2D sequence, this physician has to be there at the scanner guiding the technologist, like how they acquire the images in the sense like, where is the stenosis? How do they acquire to get that stenosis right? Like, true axial, true sagittal, true coronal through that stenosis. With 3D technique, they don't have to be, the text can run the sequence. It's isotropic sequence. And later on, we can like do any reformats we wanted. So that's the main advantage of doing 3D technique. Of course, disadvantage is, it's a 3D sequence, so it's going to take a little bit longer time compared to the 2D sequence. And of course, it's also prone for motion artifacts. Okay, so what's the duration? So basically, if you look at the entire sequence, like the all 4 sequences, so it takes around 30 minutes. So each vessel wall imaging sequence pre and post is kind of 20 minutes, 10 minutes each, so total 20 minutes. And the MR angiogram pre 5 minutes and post 5 minutes, so total it comes to around 30 minutes. So which is not bad, I mean, for this high resolution sequence. Okay, so coming on to like the applications of it. So we'll discuss a little bit about the common causes of intracranial arterial stenosis and how the vessel wall imaging helps delineate each of these entities. Okay, so the common causes are intracranial atherosclerosis. So we have vasculitis, we have reversible cerebral vasoconstriction syndrome, also called as RCVS, primary and secondary Moyamoya, and we have intracranial dissection. Okay, so what's the conventional kind of workup of these intracranial various causes of intracranial stenosis? First of all, CT angiogram, which is kind of like the workhorse, right? So next step would be MRI brain with and without contrast, plus MR angiography. So then, in suspected cases of inflammation or kind of subarachnoid hemorrhage, which is not seen, then people would do lumbar puncture to confirm those diagnoses, right? And digital subtraction angiography, which is kind of considered as to be like the gold standard for luminal imaging, right? And brain biopsy, of course, in the case of suspected CNS vasculitis to kind of confirm the diagnosis here. Okay, so why do we do vessel wall imaging then, right? Where is the role of it? So conventional imaging, remember, so DSA, CTA, or MRA, so they can identify the stenosis. They can give you only the luminal information, but cannot tell you what exactly is causing those stenosis, right? So differentiating between these entities is important because treatment for each of these entities is completely different. So high resolution vessel wall imaging can help in differentiating all these entities. Okay, and hence it can reduce the number of invasive procedures. And of course, it can help in monitoring treatment responses, especially patients with intracranial atherosclerosis when they're put on statins and other medications. So you can temporal kind of you can assess like how it responds. And of course, in the patients with the vasculitis as well, when they're put on immunosuppression. So the kind of resolution of enhancement goes along with the clinical improvement as well. Okay. And other role for vessel wall imaging is it also helps assess like the culprit or the ruptured aneurysm or even the stability of the existing kind of unruptured aneurysm. Okay. So if you look at this chart here, so this is like how like different causes of intracranial stenosis are treated, right? So vasculitis mainly by immunosuppression. RCVS, it's kind of a reversible condition, but still it needs a supportive therapy and medications which can help recover faster, right? Like the calcium channel blockers. And you have intracranial atherosclerosis where like tight blood control, blood pressure control, diabetes control, statins and aspirins are kind of very helpful in these patients. And you have Moyamoya disease and Moyamoya syndrome. For disease, usually the treatment, I mean, it's not like the treatment, but to avoid like the further ischemic strokes, they tend to do bypass surgeries, and for Moyamoya syndrome, they tend to address the managing the underlying disease, right? So these are like three different patients, right? So who got catheter angiogram. So 1, 2, and 3. So all of them show multifocal intracranial stenosis here. Can we say just based on this catheter angiogram, which is considered to be the gold standard for luminal imaging, like which of this is atherosclerosis, which of this is vasculitis, and which of this is RCVS? Kind of little bit hard, right? I mean, like with just luminal imaging, there's no way you can tell. But maybe with some history, you can speculate, okay, maybe this might be the cause, or this might be my first differential, and this might be the second. But again, you cannot confirm unless you do other investigations, right? So one of them, the patient number 1 was atherosclerosis, number 2 was RCVS, and number 3 was vasculitis. So vessel wall imaging would definitely help and identify like these entities separately. Okay. So coming to intracranial atherosclerosis. So it has got higher incidence in Chinese and Japanese population and US Hispanic and African American populations. So what do we see, in a plaque, or any atherosclerotic plaque as such? So these are like the main 5 components. Okay. So one is called as lipid-rich necrotic pore, fibrous cap, intraplaque hemorrhage, fibrovascular tissue, or neovascularization. So remember, intracranial arteries do not have vasovasorum because they kind of absorb nutrients from the CSF, right? So, but only the diseased vessel develop neovascularization. That's why the normal intracranial artery vessel wall do not enhance. If they enhance, they're always abnormal, okay? So because of neovascularization or development of vasovasorum, and of course calcifications. So presence of large lipid necrotic pore or intraplaque hemorrhage and neovascularization, these are kind of considered as high risk factors for a symptomatic plaque. Okay. So this is how this is a schematic representation of atherosclerotic plaque. So you have vasovasorum, which has developed here. You have a fibrous cap, which has ruptured and formed a thrombus here. You have a large lipid-rich necrotic core, and you have some calcification here. Okay. So we look at an example here. So basically, this 63-year-old male patient presented with left-sided weakness and numbness with kind of black spots throughout his visual fields, right? So diffusion weighted imaging on the top left. So we see a small infarct in the right occipital lobe, right? And the corresponding MR angiogram MIP images of the basilar artery shows like a tight stenosis at the P2 segment of the right posterior cerebral artery. So we went on to do a vessel wall imaging for this patient. So this is the axial reformat of that pre-contrast sequence. So you can see that's the posterior cerebral artery, and you see some kind of eccentric thickening here, which is slightly bright on T1, right? Pre-contrast T1. So, and on post, it definitely shows kind of more enhancement. So hyperintensity on pre-contrast sequence indicate intraplaque hemorrhage, okay? And enhancement, usually the culprit plaque, which is kind of has resulted in stroke, they enhance more than the non-culprit plaques. So that's again, like okay, which plaque is kind of the culprit for patient symptoms. So you can easily identify based on this vessel wall imaging sequence. Okay. All right. So this is a second example here. So 43-year-old female, with multiple risk factors presenting with a TIA. So the routine, stroke workup was done. So, diffusion weighted imaging did not show any infarction. So since this was just a TIA, MR angiogram, if you look at very carefully, there is kind of a mild signal loss in the distal M1 or maybe proximal M2 segment of that right MCA. It's easy, like when you pick up this lesion, when you have just one image with a kind of pointer towards it, right? But if you're reading like, say, 50, 60 cases every day, and it's very easy to miss this stenosis, right? So, and then like this patient also had a vessel wall imaging sequence. So this is a T2 weighted sequence. So basically showing you the atherosclerotic plaque here. So, but remember, like our protocol does not include T2 weighted sequence, just like to keep, time. We don't want the time penalty. So that's why we don't do T2 sequence. T2 sequence helps only in case of like characterizing the atherosclerotic plaque. Otherwise, for rest of the entities, it's not going to be of that much help or make difference like in how you interpret these studies. Okay, so that's why we usually don't do T2 sequence in our protocol. So if you look at this sequence, so you see like a large atherosclerotic plaque here. So this bright line here, so that is nothing but the fibrous cap, right? And the dark line underneath it is the lipid-rich necrotic core. Okay, so that's the pre-T1, and the post-T1 shows enhancement. So again, indicating culprit plaque, right? So you can note the difference. So easy to miss on luminal imaging, but very hard to miss on your vessel wall imaging, right? The abnormality. So that's the beauty of this vessel wall imaging sequence. Okay, so this is like 3 different patients showing you like how a fibrous cap for the atherosclerotic plaque looks like. So the one, like the image A on your left, so shows like the bright line here. So that's the fibrotic cap, and that's how it's supposed to look like. On the second patient, so you barely see that bright line, right? So that means the fibrotic cap is kind of significantly thinned out. And in the third patient, you don't see anything that is bright. All you see is some filling defect. So this is like the disrupted fibrotic plaque. And these tend to be more symptomatic because the underlying adipose tissue or the lipid-rich necrotic core has been exposed to the circulation. Okay. And this is an example like how serial imaging can help assess like the plaque, like when patients are put on treatment. So this is like December 22, June 23, and December 23. Patient was started on statins. Like for this patient, you can see like when they started the treatment, so the plaque was kind of intensely enhancing. It was more kind of an eccentric enhancement. Progressively, enhancement decreased, kind of septations were formed, and then like at the end of 1 year, you could see like enhancement has significantly gone down, and even the luminal dimension kind of has improved. So it also helps in assessing or serially following up like these patients who are put on treatment. Okay, that's one utility of vessel wall imaging. So then next, coming to the second cause of stenosis, that is vasculitis, which is an inflammatory kind of a condition where there is inflammatory infiltrate within the blood vessels, resulting in fibrinoid necrosis, which can result in stenosis, bleeding appearance, occlusion of the lumen, or even aneurysm formation, right? So it can be primary or secondary. Primary is where you don't have a systemic vasculitic process. Secondary is where you have a systemic vasculitic process and secondary involvement of the CNS. Okay. So this is just a schematic representation where kind of showing you the ischemic like sequelae or the hemorrhagic sequelae of untreated vasculitis, right? So it can result in luminal narrowing and finally resulting in ischemic strokes, or the vessel wall kind of might weaken, and rupture resulting in pseudoaneurysms or formation of, intracranial hemorrhage. Okay. So diagnosis traditionally has been through CSF studies. Neuroimaging plays critical role. And of course, definitive diagnosis is by brain biopsy, right? Brain and meningeal biopsy. For systemic causes, serum and serum analysis is done to look for other systemic inflammatory or autoimmune conditions. Okay. So how does vessel wall imaging help in vasculitis? So what do we see basically? So what we see is like there is circumferential uniform thickening of the vessel wall, which can be more like a multifocal or it can be diffuse process. Okay. And on post-contrast imaging, you are going to have very intense, smooth circumferential enhancement. Since it's an inflammatory process, so the enhancement is going to be very intense. Sometimes even it's so intense that even it extends into the adjacent PL surface, goes beyond the margin of the vessels. Okay. And it can affect any of the intracranial vessels, ranging from your larger, like the carotids or basilar artery or vertebral artery, to more distal cortical branches. And remember, like although gold standard for diagnosis is biopsy, but it all depends upon where exactly the biopsy was performed. But if unfortunately, if the biopsied area was not involved with vasculitis, then it's going to be negative. So that's false negative results can occur in up to 1/4 of the patients, right? So one other utility of vessel wall imaging is it can help guide, like, it can show you, okay, this is the target where like biopsy can be performed to improve the sensitivity or the yield of this biopsy. Okay. So this is an example. So this 20-year-old male who presented at an outside hospital with a stroke. So if you look at the MIP image of TOF MRI, so you see a like tight stenosis in the left A2 segment with preserved distal flow. Okay. And also the left M1 segment, there is kind of absent flow, like, in the inferior division. Okay. So this is the coronal reformat of T2 and pre-contrast T1 and a post-contrast T1. So what do we see? So we see kind of uniform thickening, circumferential thickening of the vessel wall there. So you can see it on pre-contrast T1 as well, and kind of an intense homogeneous, like, smooth enhancement of the affected segment. So that's again typical for a vasculitic process. Okay. And this is another example of this is in this time it is like the secondary CNS vasculitis, because this patient has like a systemic vasculitic process like Behçet syndrome. So you see like this patient has some infarcts in the right gangliothalamic region and in the right parietal lobe. ASL perfusion showed decreased perfusion in that region. And on the TOF MRA, you can see like the stenosis in the right posterior cerebral artery and the right M1 segment there. Okay. And post-contrast imaging, like the pre and post-contrast high resolution imaging, you can see like intense enhancement along the vessel wall of that affected segment of the PCA. And you can see the enhancement goes much beyond the vessel wall. That is like the PL enhancement is there. So very typical for a vasculitic process. Again, if you pay attention, the enhancement is pretty uniform. It's not like, eccentric enhancement. It's pretty diffuse, pretty uniform, like circumferential enhancement. That is again characteristic for a vasculitis. Okay. And this is an example for like how serial follow-up can help, or document the resolution of, resolution of the inflammation, right? So this just before the start of treatment, where you have intense circumferential enhancement, which is smooth, and mid-course of treatment, it has improved, and finally, it has completely resolved. So again, documenting like which again correlates with the clinical improvement as well. Okay. So coming to RCVS, this is a non-inflammatory process usually affecting young and middle-aged women. So characterized by intracranial vasospasm, which tend to resolve on its own in 1 to 3 months. But the common clinical presentations includes severe thunderclap headache, which is kind of characteristic, at least for the neurologist, and of course, it has other neurologic symptoms as well. So there are triggering factors associated with this, especially smoking, medications, drugs like amphetamines, cannabis, and even other clinical conditions like eclampsia, postpartum status, and other important risk factor is having, patients with psychiatric disorders like depression on SSRIs. So what does conventional imaging reveal? So usually, they can show you multifocal infarcts, subarachnoid hemorrhage, which tends to be kind of more like a focal cortical subarachnoid hemorrhage. These patients also can have intraparenchymal hemorrhage, that is a subcortical hemorrhage, and rarely press-like appearance on imaging. Okay, on vessel wall imaging, there's going to be like a smooth circumferential mild vessel wall thickening. And most important thing is there's not going to be a vessel wall enhancement here. So multifocal narrowing with vessel wall enhancement suggests vasculitis in appropriate clinical context. If the same like multifocal narrowing without enhancement would indicate RCVS in an appropriate clinical context. Okay. So these, remember, vessel wall imaging is an adjunct to the existing imaging. It's not like you can't use this as a standalone imaging process. Having only vessel wall imaging sequence and making the diagnosis probably is not going to be helpful for you. Okay. So an example for RCVS. So you have like this ADC image showing multifocal infarcts, and TOF MRA showing kind of mild multifocal narrowing, especially the A1s, A2 segments and M1 segment. And vessel wall imaging pre and post does not show you any vessel wall enhancement. And a patient was put on treatment, after 3 months of follow-up. You can see the nice crisp looking vessels kind of completely resolved with clinical symptoms, and also the imaging findings were completely normalized. Okay. So next, coming to Moyamoya. So this is a progressive vascular vascular disease, resulting in narrowing or occlusion of the supraclinical carotid and the terminal ICA. Okay, so there are two things. One is Moyamoya syndrome, where there is a predisposing condition which is resulting in chronic steno-occlusive disease involving the carotid terminus. Okay, Moyamoya disease is more like an idiopathic process which has a higher incidence in Japanese population. Usually they tend to affect bilateral ICA, kind of asymmetric to one side. Okay, and how about vessel wall imaging? So if you look at Moyamoya syndrome, so it's going to reflect the underlying process. Say like if there is atherosclerosis resulting in Moyamoya syndrome, then the imaging appearance of that would be kind of characteristic for atherosclerotic process. If it is something like post-radiation vasculitis, then there will be uniform vessel wall thickening and enhancement. But whereas Moyamoya disease, this is kind of at least later in the disease, this is a non-inflammatory process. There is kind of significant vessel wall thickening with chronic steno-occlusive disease, but there is no vessel wall enhancement. But some literature say, like early in the stage, there is inflammatory kind of a stage where you can, if you scan them during that phase, you may see enhancement. But again, like, I don't know, there is no way to differentiate, okay, is this something else or is it Moyamoya disease in the early phase you are catching, right? So most of the time, for more practical purposes, Moyamoya disease wouldn't enhance and Moyamoya syndrome would behave like based on the underlying etiology, okay? This is what I would remember with Moyamoya. So this is an example where 29-year-old female presenting with Moyamoya disease. So you can see bilateral carotids are affected. The terminus are almost kind of gone on the left side, and right side there is some narrowing and you see numerous collaterals there. And this is the catheter angiogram of the left ICA. You can see like the crack-like vessels or the Moyamoya pattern or puff of smoke collaterals there. And vessel wall imaging, you can see like circumferential diffuse wall thickening there in that terminal segment of the ICA, proximal M1, A1 segments, but no enhancement as such, right, on post-contrast imaging. Okay. So this is another example, 45-year-old female presenting with Moyamoya syndrome due to atherosclerosis, left-sided weakness and seizures. So you can see on diffusion weighted imaging, there are like recent infarcts in the right frontal lobe, and angiogram of the right and left ICA shows a steno-occlusive process, kind of more severe on the right side compared to the left with numerous collaterals. And you can also see the basilar artery with multifocal stenotic disease there. Okay. And vessel wall imaging sequence post contrast, you can see the enhancing infarct here in the right frontal lobe, and you can see kind of eccentric enhancement in the right MCA. You have more medially enhancing like enhancement in the left ICA, like left MCA, and also like the right posterior cerebral artery, you can see kind of eccentric enhancement here, indicating atherosclerotic plaques. Yeah. Okay. And this is another application of vessel wall imaging. So one on the left side is an unruptured aneurysm in a 49-year-old arising from the basilar tip. You can see that on your MIP image. And on vessel wall imaging, you can see like a nice smooth wall of the aneurysm without any enhancement, right? So whereas on your right side, you can see this patient with 53-year-old presenting with headache due to subarachnoid hemorrhage. So when they did luminal imaging, it showed multiple aneurysms, okay? But one other thing about this sequence is like the aneurysm which has ruptured would show wall enhancement, or the aneurysm which is impending rupture, which are unstable, also would show wall enhancement. So it's believed like before or during rupture, there is preceding inflammation in the vessel wall, aneurysmal wall. So that's the kind of theory behind like why there is enhancement of the aneurysmal wall when they are like unstable or like when they have ruptured. So that helps in identifying the culprit aneurysm, especially patient presenting with subarachnoid hemorrhage, and there are multifocal aneurysms, and it's hard to figure out based on the subarachnoid hemorrhage distribution or like the shape or configuration of the aneurysm. If you're unable to decide which one has ruptured, vessel wall imaging can help you pinpoint, okay, this particular aneurysm has ruptured this time, so probably it's worth treating that rather than clipping like all or treating all the aneurysms, right? Okay. So this is like the ASNR recommendation. It came out a few years back, like a white paper. It's like this is what they recommend. They classify into 3 different categories. One, where it can be a likely and useful adjunct to your conventional imaging. Second, possibly a useful adjunct to conventional imaging. And third was like currently in domain of research. So where it's going to be likely useful, one is like to differentiate various causes of intracranial intracranial vascular narrowing, especially with differentiating atherosclerotic plaques, vasculitis, RCVS, intracranial dissection. Also, if there is a symptomatic disease, but nothing like a stenotic segment on the vascular imaging, like the conventional imaging, again, you can use vessel wall imaging to identify these conditions. Okay, and where it can be like a possibly useful as an adjunct, one is to locate the plaque in relation to the branch vessel ostia, especially when in neurointervention is considering like angioplasty or something. You don't want to like angioplasty a plaque which is close to an ostium and kind of seal the ostium off, right? So that can help like to localize like where the plaque is in relation to the ostium. Another thing is to assess the atherosclerotic plaque activity when patient is put on treatment, similarly vasculitic activity. And also like in patients with suspected vasculitis, you can do this sequence and tell the surgeon, oh, hey, like this area, probably if you biopsy, the yield would be higher. So that's another way. Another thing is when patient has a ruptured aneurysm presenting with acute subarachnoid hemorrhage with multiple aneurysms. So if you want to localize what aneurysm has ruptured, then this sequence can be of a possible useful adjunct. Okay. So domain of research is like following up with unruptured intracranial aneurysms to see how they behave over time. So that's like the recommendation from ASNR consensus committee. So this is just the summary, like what we discussed, how the atherosclerotic plaque would look like, vasculitis, RCVS, Moyamoya. Dissection, I mean, I did not show you any image, but it would just show you like either like a focal intramural hematoma or an enhancement with enhancement, or a dissection flap can be seen sometimes. Okay, so I think this concludes my vessel wall imaging topic. Thank you.
Yeah, thank you, Santosh. You're continuing with the second lecture, right? On spontaneous intracranial hypotension.
Yeah, I can continue. I mean, unless there is some question or something, I can take it. If not, I am okay to continue with the second topic.
Okay, audience, if you have any questions, please feel free to ask them.
Sir, I think there are questions in the Q&A section.
Okay, madam. Let me continue with the second talk then, and then we'll address both together then.
Yes, sir. Okay.
Okay, thank you. All right. So my second topic for the day is spontaneous intracranial hypotension, finding the leak. It's an algorithmic approach for diagnosis and treatment. So this is one of my favorite topic. Okay. So again, I don't have any relevant financial disclosure objectives for this talk. So we're going to discuss some clinical presentation of SIH and how to confirm the diagnosis of SIH, and discuss the MRI findings, brain findings of SI in SIH patients, and various causes or pathophysiology of spinal CSF leak, and role of Bern score, which is a predictability score based on MRI findings in the brain. And we are going to discuss some myelographic techniques, kind of which can improve your outcome or detection of improve the what do you call, like the yield of your targeted procedures. Okay. And briefly, we'll discuss about MR and radionuclide myelography, which is kind of very rare. People usually don't do it, but sometimes, in case if you come across these, I mean, so just at least you should have seen some images out of it. Okay. And briefly, an understanding about available treatment options. And at last, we are going to have like a flow chart which kind of describes what algorithm we follow here at Rush in managing these patients with SIH. Okay, brief introduction. So in terms of CSF, production, absorption, and flow, as we know, play a key role in the dynamics of intracranial pressure, right? Any alteration in the pressure or volume would lead to neurological symptoms, particularly headache, right? So this is an important treatable secondary cause of headache. So annual incidence is said to be around 5 per 1 lakh population. So peak incidence is said to be around 40 years of age group, but it can occur in children as well as older adults. Common in females, and some risk factors including connective tissue disorders. Okay. So pathophysiology of headache. So there are like 3 different theories that has been proposed why these patients have headache, right? So one of them is say when there is loss of CSF, the buoyancy is gone, right? So the CSF provides a cushion where the brain is kind of floating in it. When there is no, the volume or pressure drops, so the brain sags. Once it sags, so there is like a tugging on the pain sensitive structures. So that results in headache. So the other theory is whenever there is hypovolemia with or without decrease in pressure, so that results in secondary intracranial vasodilation. So that can also result in headache. And the third theory is there is increased compliance of the distal spinal CSF space because of the leak. And that results in abnormal distribution of craniospinal elasticity, resulting in headache. So headache, mainly it's said to be orthostatic, but need not be always. Sometimes even patient may not have headache, which is a very tricky situation to even make the diagnosis or even suspect this diagnosis, right? So usually it tends to be more prominent later in the day. Okay. So can be sudden or gradual onset, can be throbbing or dull pain, and rarely it can present as a thunderclap type. So it can range from mild to incapacitating type, and typically it's relieved by recumbency and do not usually respond to analgesics. Okay, there are various exacerbating factors, especially upright posture, head movement, coughing, straining, sneezing, jugular venous compression, and even high altitude exposure can exacerbate symptoms here. Okay, so it's believed like, any new onset daily persistent headache in a young and middle-aged adults should raise suspicion for SIH. Okay, there's a big laundry list of clinical symptoms, other clinical symptoms like where patient can present with, including neck pain, stiffness, nausea, vomiting, all like the vertebrobasilar symptoms, including vertigo, dizziness, tinnitus, muffled hearing, hyperacusis, unsteady gait, can go up to even cognitive decline. Rarely because of the herniation, patient can go into obtundation and coma. Sometimes even because of the slow flow, venous congestion and slow flow in the intracranial vessels, that can result in venous thrombosis. We have seen venous infarcts, which is secondary to intracranial hypotension. Okay, so diagnostic criteria. So the International Classification for Headache Disorders, third edition, puts out this diagnostic criteria. So A, what it says is anything that is fulfilling criterion C, which is headache that has developed in temporal relation to the low CSF pressure or CSF leakage, or has led to its discovery, or either or both of the following. That means if you document low CSF pressure, which is considered as like less than 6 centimeters of water, or if you document any evidence of CSF leakage on imaging, so then also you can blame the headache on intracranial hypotension. Okay, and there should not be any other alternative diagnosis which could explain patient symptoms. Okay, so coming to CSF pressure. So if you look at this pie chart, so this is like the low pressure, right? And if you pay attention, this is only seen in kind of 1/3 of the patients, right? Up to 61% of these patients has normal CSF pressure, and only around 5 and even 5% patients can have higher CSF pressure. So what does this tell you? So what it tells is like it is specific but not very sensitive. So we do not use CSF pressure measurement to make the diagnosis of intracranial hypotension. Okay, so that's the normal pressure. So low pressure is very insensitive to make the diagnosis. It is specific. If you see it, okay, it's good. If you don't, then you can't say anything. That's why we don't measure pressure to make the diagnosis. Okay, so what's the imaging workup in a suspected SIH patient? So first thing we do is MRI brain with and without contrast. Okay, so depending on the imaging findings, our next step is we do a non-contrast MRI of the entire spine. So with that would include a specific sequence that is a heavily T2 weighted sequence with fat suppression. So with multiplanar reformats we are going to do. Okay, it's a 3D sequence. And then based on those imaging findings, we are going to next kind of select a problem solving imaging where there are like multiple options that are available. We'll look at those. Okay, so what are the brain imaging findings? So all these imaging findings in the brain are based on this doctrine, Monro-Kelly doctrine. So what it means is the cranial vault is a rigid structure, right? So it has a fixed volume in it. Most of it is constituted by brain, blood, and CSF. So if any one of them decrease, there is compensatory increase in the other two. So that's how like the imaging findings in these patients develop. So when CSF volume goes down, the other stuff, brain volume can't increase, right? So there is no brain growth sudden. So that changes has to happen in the circulation, intracranial circulation. So that's all like the imaging findings are based on this. Okay. So most important thing are these like the top 5. So first and foremost is diffuse, smooth, dural pachymeningeal thickening and enhancement. Okay, so all these words are important. It has to be diffuse, it has to be smooth, it has to be kind of thickened, and it has to be enhancing. Okay, so even if you look at the internal auditory canal, you would see the dural enhancement going into the internal auditory canal. So that's your clue there. Okay, so next thing is venous distension sign, brainstem sagging, subdural effusions or hematoma, pituitary enlargement, and decrease in the size of ventricles and basal cisterns. This is not like a kind of a common finding. This is a rare, but at least these 5 top findings you would kind of encounter in these patients. Not all of them, but at least some of them. Okay. And remember, in 10 to 20% of the cases, the brain can be completely normal. So just normal MRI brain does not exclude SIH. If the clinical suspicion is strong, you would still proceed with your second step, which is the spinal imaging, even with normal brain MRI. Okay. So this is our first imaging findings, which is the dural enhancement. So it has to be diffuse, thickening, and smooth enhancement are the characteristic imaging findings. So if you look at this image on the coronal post-contrast, you can see the pachymeningeal thickening here along the cerebral convexity, as well as the tentorium here, right? So most common finding, like the 83% of the cases, you see these. Differential should be metastatic disease, especially if you have calvarial metastasis, you can have reactive dural thickening and enhancement, but those enhancement wouldn't go into the internal auditory canals. Okay. So if it is a granulomatous disease or dural metastasis or other autoimmune conditions or secondary enhancement due to underlying subdural hematoma, they tend to be more focal and more nodular enhancement, not like diffuse and smooth. Okay. So diffuse smooth dural enhancement in the setting of orthostatic headache almost always indicate SIH. Okay. Next is venous distension sign. So if you look at these images, one on the right side, you can see the normal configuration of the venous sinus, right? So what we do is we use the sagittal post-contrast or a sagittal MR venogram in the mid dominant transverse level. So we look at this sign. So this is like how the normal sinus looks like. The margins are either concave or straight line, like a triangular shaped appearance. But if you look at this abnormal sinus, it has like a bulging walls, like the biconvex margins. Okay, so that's abnormal here. And this is the normal sinus. This is abnormal sinus. Okay, and this is seen in patients with 75% of cases with SIH. Okay, and this is because of, again, more blood flow within the veins. Okay, venous congestion. All right. So third imaging finding is brainstem sagging. So what we look here is for the direction of the third ventricle floor. Okay, so normally it has to be kind of like directing upwards like this. So this is a normal one. So if you look at this, so this floor is kind of pointing down or even flat, right? If it is flat or pointing down, that is abnormal. So that's like the brainstem sagging. Other things you look for is this pontomesencephalic angle. So this is the mesencephalon and this is the pons and this is that pontomesencephalic angle. So you don't see that angle because the mesencephalon is bulging on to the pons here. And the prepontine cistern is kind of effaced, and also the mammaropontine distance is reduced. And also you can see like the cerebellar tonsillar kind of is herniating through the foramen magnum. So that's like an acquired Chiari appearance, right? So we see these findings in up to 61% of cases. So that's your direction of the floor of third ventricle. This is normal, which is kind of upstroking. If it is flat or downstroking, that's abnormal. And we look for this pontomesencephalic angle. Usually it's kind of more like an obtuse angle normally. In affected patients, it's going to be more like an acute angle. And also the mammaropontine distance is going to be reduced in these patients, as is the prepontine distance. Okay. So other imaging finding, which is kind of considered to be the least common finding, is subdural collections or subdural hematoma or effusions. So when they are present, they are usually bilateral in 90% of the cases. Only in 10% they can be unilateral. Okay. So if you see a young patient without significant trauma, with bilateral kind of nearly symmetric subdural collections or hematoma, always think about intracranial hypotension. Okay. All right. So the other imaging finding is pituitary enlargement, which can be rarely mistaken for a pituitary adenoma. And this is again because of the venous congestion here around venous plexus around the pituitary kind of engorged, kind of giving the appearance as if like the pituitary gland itself is bigger or there is some underlying lesion here. Okay. So that's another imaging finding. So coming to pathophysiology, so there are different types or the causes. So the type 4 is more like an indeterminate source. So where like no matter what imaging like you do, you don't see like where exactly the leak is happening. Okay. So the other type 1, 2, and 3, where they are like a specific cause. Type 2 is the most common one, which is because of the meningeal diverticulum. So recently there was like a publication saying like the diverticulum is like a misnomer because diverticulum is kind of synonymous with the perineural cyst. So they kind of proposed the term arachnoid herniation. So we will look at this kind of in a couple of minutes here. Okay, and that's type 2. Type 1 is where like the more like a dural tear, usually ventral, because of the disc osteophyte complex, and rarely can be posterolateral because of the osteophytes from the facet or ligamentum flavum ossification. So they tend to have almost in 100% of the cases tend to have epidural fluid collection. But whereas type 2, only like 1/4 of these cases can have epidural collection. And there is something called as CSF to venous fistula, which is type 3, where you do not have any epidural collection. Okay, so this is like the direct communication with the dorsal nerve root sleeve containing CSF with the adjacent veins, where there is free flow of CSF into the venous structures. There is unhinged flow. Okay, that results in intracranial hypotension. So these are the most difficult ones to make the diagnosis. Okay, and some important points here. So if the CSF leak is at the level of skull base, they do not constitute as a source of SIH. When we speak about SIH, that means the leak is at the level of spine. Okay. And till recently, there used to be like thought like there is only one source of leak. But most recent, there's a publication like saying like, you can have multiple sources of leak. That means like patient can have like 3 or more CSF to venous fistula at different levels. So if you see one, I mean, there should not be like a satisfaction of search because you may find more than one there. Okay. So coming to type 1 pathophysiology. So these are because of the ventral tears, usually in the thoracic spine, like where you have a disc osteophyte complex tearing into the thecal sac. And these patients, this is called as a high flow leak, and you would have epidural CSF collection. Okay. So ventrally, it's because of the disc osteophyte complex, and more laterally, posterolaterally, is because of the ligamentum flavum ossification or facet osteophytes. And as I said, these constitutes what's called as high flow CSF leak. So this is an example here from the literature. So this particular image, a set of images depict an important sign on T2 weighted MR imaging. So that's called as a flow void sign. Okay, so this is kind of a more recently described imaging finding. So what happens is because of this rent in the dura, where the CSF is leaking from the subarachnoid space into the epidural space, so the leak is so fast, it tends to lose the signal. So you see like this kind of smudged out loss of signal here. That is called a flow void sign. And this is seen only in a 2D sequence like this, because this is a 3D T2 space where you do not see that abnormality. So remember, if you're suspecting a high flow leak, like with the ventral tear, so look for this sign. So this will help you. Okay, this might be the area of leak, and I'm going to focus in this area when I do my problem solving imaging. So that will help you. Okay, so these are like two examples showing like the flow void sign. Next, coming to type 2, as I said, meningeal diverticula is considered to be a misnomer, although the pathophysiology is said to be like there is a lateral dural tear, like just underneath the nerve root axilla. So there is a dural tear from which the arachnoid herniates. And this fragile arachnoid, which herniates through it, is kind of, can easily rupture without significant trauma. And when it ruptures, that results in CSF leak. Some of them can be high flow, some of them can be slow flow. So depending on what type it is, so you may or may not see epidural collection. Okay. So usually occurring in thoracic nerve roots. And remember, the perineural cysts are different from these arachnoid herniations. So the diverticula, people say it is synonymous to perineural cysts. That's why they don't use the term diverticula anymore. Okay, so this is that article which was published in Journal of Radiology. Like they come basically like they kind of correlated these type 2 leaks with intraoperative data and concluded that this is because of the lateral dural tear kind of having arachnoid herniations, and they described an imaging finding called as a bud on branch sign, which is very specific. If you see this sign, it almost like 100% specific. It indicates like type 2 leak, although the sensitivity is kind of still like moderate, close to 80% sensitivity. So that's a schematic representation of nerve root perineural cyst or the diverticulum, and the arachnoid herniation, which is like the more like a pathologic condition. This is like more physiologic condition. This is like the pathologic condition. So there is a rent in the dura and the arachnoid herniates, and that leaks the CSF through that tear. And this is what is described as the bud on branch sign. So you see them on your coronal T2 MR myelography, where if you see this thing, that is the nerve root, and just underneath the nerve root, which is called the axilla of the nerve root, where you have this broad-based outpouching, which is nothing but the arachnoid herniation. And this is how it looks like on MR, like the bud on branch. Okay, so that's like a clue. And these, again, as I said, they can have epidural collection or they may not have epidural collection. So this patient tend to have an epidural collection with on the myelogram. You can see the epidural contrast here, which is separate from the CSF contrast. Okay, bud on branch. Type 3 is CSF to venous fistula, where like the normal CSF drainage is like through the arachnoid granulations, which kind of drain the CSF into the adjacent veins at the level of neural foramina, right? So if there is by any reason there is a rupture of these arachnoid herniations, there is unhinged flow of the CSF into the veins that results in CSF to venous fistula. So these are always considered as slow flow, intermittent flow, and you do not have epidural collection in these cases. So on regular MRs, it's going to be like as if there is no kind of no abnormality at all. You have to do like a specific type of myelogram to make sure like you see these entity, and these are the difficult ones to make a diagnosis of. Okay, so that's like the schematic representation of normal venous plexus, and you can see these arachnoid granulations draining the veins. If any one of them rupture, that results in CSF to venous fistula. Okay, and this is that article which I was talking about, describing multiple synchronous CSF to venous fistula, which can be like 3 or more at the different levels. Okay. And coming to a Bern score, which is nothing but a predictive scoring system based on MR imaging findings. So basically, it stratifies the patients as high, intermediate, and low probability of identifying CSF leak on problem-solving myelographic images. So basically, it helps you select the patients like who is going to be, okay, if the Bern score is higher, I'm pretty sure I'm going to see something on myelography. If it's very low, then probably my kind of outcome of myelography is not going to be great. But again, that doesn't mean we are going to exclude all the patients with low Bern score from getting imaged, right? So it all depends on case-to-case basis. If there is very high clinical suspicion, you would still go ahead with your problem-solving imaging to make sure like you're not missing any diagnosis there. Okay. So what does this include? So it has major criteria, which carries 2 points each, and a minor criteria, which has 1 point each. So major criteria includes pachymeningeal enhancement, engorgement of venous sinuses, and suprasellar cistern less than equal to 4 millimeter. And you have subdural collection, prepontine cistern like less than equal to 5 millimeter, and mammapontine distance less than equal to 6.5 millimeter as minor criteria. So for high probability, you need to have 5 to 9 score. And if you have this, your chances of seeing the leak is almost close to 100%. If it is intermediate, then it can range from anywhere from 7 to 70%. And if it's low, it's pretty low yield. Okay. And coming to spine imaging. So basically, we are doing this to identify the exact site of leak, right? And remember, like the type 4, like even like 1/4 to 1/3 of the patients, you may not be able to see the leak in the first study. Okay. So, and that's why choosing an appropriate modality and appropriate modification of the technique is important so that your success rate improves. So what are the two steps in spine imaging? First thing we do is a screening MRI, a screening imaging. So mostly it is because it's by standard, without contrast MRI of the entire spine, which would include a heavily T2 weighted fat suppressed 3D sequence. Okay, if patient for some reason cannot get an MRI, then other alternative would be to get a standard regular, the prone CT myelogram. Okay, based on the imaging findings, what we see, we tailor the next what's called as the problem solving imaging. So what are the options we have? So we have a dynamic myelogram, which can be digitally subtracted or an unsubtracted. Okay, so these are like the regular prone myelograms, and we can do these in the decubitus positions as well. So they are like the lateral decubitus dynamic myelograms. And then we have prone dynamic or ultra fast CT myelogram. And the fourth one, we have the lateral decubitus, the dynamic CT myelogram. And as I said, MR myelogram with intrathecal gadolinium injection and indium 111 cysternography. So these are like not so commonly used. And I would say practically, probably these are kind of least used modalities, I would say, for this particular condition. Okay. So what are the things we are looking for initial screening imaging here? So couple of things. One is you're looking for epidural fluid collection. If there is epidural fluid collection, that indicates it is a high flow leak. So chances are either it is a type 1 leak or maybe 1/4 of the type 2 leaks, what we saw, right? So, or if we see like say like bud on branch sign, then we know, okay, this is going to be a type 2 leak. So I'm going to tailor my kind of next problem solving imaging. So I'm going to do a decubitus myelogram on that side. So that's like, that's why this screening MR is important. And also if there is like say epidural collection, I'm going to look for, are there any large disc osteophyte complex, which would tell me, okay, this is where I'm going to focus upon to make sure like I'm not going to miss a leak at this site. So these are the things which we look for. Okay, and based on these, I'm going to tailor my appropriate problem solving imaging based on these findings. Okay, so this is like the first kind of modification of like the problem solving spine imaging, which is called as dynamic myelogram with or without subtraction. So this I'm not going to go into the technical details here. So if you see these images here, so this is the digital subtracted myelogram, where you have like two column of contrast here. So the one more posterior is in the thecal sac, the one more anterior column is in the epidural space. And you can see a thin sleeve here where the leak of contrast, you can see like the rent which is leaking the contrast here. So that is like a type 1 leak where there is ventral dural tear and leaking of the contrast. And subsequent CT demonstrate like a small disc osteophyte complex at that level. Okay. Having thinner slice CTs, we usually recommend like 1 millimeter, both bone and soft tissue reconstructions to help identify these small osteophytes there. Okay. So what's the advantage of this? So advantage is this has very high temporal resolution, and you don't miss any of the leaks on this if the study is done properly. But disadvantage is the field of view. You can't cover the entire spine in just one go. So that's why if you have a particular suspected level, then you can focus on that and then you can do these studies. So it's kind of very easy. If you don't have any particular level of suspicion, then I would choose a CT myelogram so that I can sweep the entire spine to make sure I'm not missing out on any particular location there. Okay. And whatever we're looking here, so basically splitting of the contrast column. So basically two contrast column we are looking at. So this is another example where you have these high resolution T2 weighted images with fat suppression showing you the epidural collection. You can see the dura has been displaced ventrally. Same way axial MPR images showing you the epidural collection where the thecal sac is pushed anteriorly. And this is an unsubtracted dynamic myelogram. You can see splitting of the contrast column in a swimmer's view and where the leak is arising from the upper thoracic region here. And the subsequent CT showing like a osteophyte tearing into the thecal sac there. Okay. And next modification is ultrafast or the dynamic CT myelogram. Here, basically what we do is we do a lumbar puncture under CT fluoroscopic guidance, and we're going to inject contrast, keeping the patient's hips kind of raised above the level of patient's shoulder. So basically it's like a prone Trendelenburg position. And when we inject contrast, we simultaneously start scanning the patient. Like we sweep from caudocranial and then sweep back from craniocaudal. So usually they suggest you do this, either you reach maximum 6 sweeps or you kind of identify the leak. Okay. So the frequency of the sweep depends on how fast the contrast is flowing. Okay. Again, one can imagine, the disadvantage for this is going to be like the radiation dose. And of course, patient being on the table with, prone Trendelenburg. So it's kind of a discomforting position. And advantage is very high temporal resolution, very high spatial resolution. And also like you can cover the entire spine, even if you don't have any specified level of suspicion, you can rescreen the entire spine here. Okay. And imaging finding, of course, we are looking for splitting of the contrast column, one in the epidural space and the other one in the thecal sac. Okay. So this is another example where you have like patient getting an MRI brain for suspected leak, SIH. So basically you have diffuse dural thickening and enhancement, and the screening MR T2 space, 3D T2 space, which is nothing but the MR myelogram, T2 MRM. So showing no epidural collection or any diverticulum or any bud on branch. So based on this, we decided to do a decubitus dynamic myelogram. So if you look at this dynamic study, so what we have is like a contrast column, which is kind of heading into the thecal sac more cranially. And we started seeing this kind of linear branching contrast density here. If I zoom it up, you can see that's the venous structure, the paravertebral vein being opacified from the leaking contrast from the thecal sac. So that is CSF to venous fistula. These can be very subtle unless kind of you're looking for them. It's easy to miss them. Okay. So subsequent CT shows you like the contrast density is already there in the renal collecting system. That's your clue. It's an indirect clue. That means the contrast is already in the circulation. If you have done a clean lumbar puncture and injection, so you don't expect contrast to be that fast by the time you perform your CT myelogram. You're not going to have contrast in your renal collecting system unless there is extravasation in the epidural space or something. So if in a clean myelogram patient, if you see this contrast, it's a clue saying like, okay, the contrast is entering the circulation early. So there may be a CSF to venous fistula. Okay. And subsequently, at that level, suspicious level, we started seeing like the venous enhancement here on the left side at T12 L1 junction. I mean, we have this opacifying paravertebral vein suggesting CSF to venous fistula. Okay. And this is like the surgeon went ahead and clipped that fistula, and following clipping, patient's symptoms were resolved, and follow-up imaging, shows complete resolution of the dural thickening and enhancement, which we saw in the preoperative study. Okay. So again, I'm not going to getting into details of this decubitus myelogram here. This is another example of decubitus myelogram. And you can see like the venous structure that is enhancing, and the contrast column, it's kind of already moved ahead in the kind of lower thoracic region. Okay. So what are we looking for here on the dynamic lateral decubitus myelogram? Basically, we are looking for an opacification of the paraspinal vein. Usually they tend to be associated with a diverticulum or a lateral dural tear. Okay. And again, advantage, as we said, like for all this dynamic myelogram, most important advantage is very high temporal resolution. But again, disadvantage, remember, you're not going to cover the entire spine in one go, right? So you need to have a level of suspicion. And this is an example, from the literature of a lateral decubitus myelogram. So basically you can skip the dynamic myelogram and just do everything under CT guidance itself. So basically you put the patient in decubitus position, you do a lumbar puncture under CT, like fluoroscopy guidance, and then keep the hips raised above the level of shoulder, inject contrast and watch the contrast column flow. Okay, so and you can see the paravertebral kind of veins kind of enhancing if there is any CSF to venous fistula. Sometimes you may not see them because they are intermittent. Doing certain maneuvers can help kind of identify these paravertebral veins, especially breathing techniques. Full inspiration or resisted inspiration, what's called as, so can help. Some people even use inject intrathecal kind of normal saline before even doing the study, so that they normalize the volume or pressure. So that improves the chances of identifying these intermittent leaks. Okay. So basically, we are looking for any hyperdense paraspinal vein with more than 70 HU, ounce fill units. So these are just examples from the literature. So MR myelogram, I'm not going to go in details again. So basically what we do is, under fluoroscopy guidance, you're going to do a lumbar puncture and inject iodinated contrast mixed with some gadolinium, like usually half cc. Before that, you do a fat suppressed T1 weighted imaging, pre-contrast imaging, then do your injection. And then after 1 hour, you scan these patients with same sequence, T1 fat suppressed. So basically, you're going to see enhanced, CSF with gadolinium. But disadvantage is, it is not FDA approved, and long-term consequences or results of this intrathecal injection is not known. So we have to disclose to the patient in case if you're planning to do these studies. Okay. Advantage. So they say like even like 20% of the CSF to venous fistulas, which were negative on prior CT myelogram, can be identified on these. Okay, but disadvantage is, they are prone for susceptibility artifacts. And of course, the spatial resolution is not as great as your CT. Okay. And important thing is these are used to look for intermittent leaks or delayed leaks. Same way, cysternography. So usually we don't do this kind of quite often. So basically what they do is they inject indium 111 DTPA by doing lumbar puncture, and images are acquired both immediately after injection at 1, 2, 4, 24, even up to 48 hours. So basically we are looking for something like moderate sensitivity and specificity in identifying slow and intermittent leaks. So what are the things we are looking for on imaging here? So two things. One is direct evidence. Another is indirect evidence. Direct evidence is where you have leak, like paraspinal radio tracer is leaking and accumulating there, right? So that's like your clue. Okay, so this is where it's leaking from. If you don't see these, then we look for indirect evidence. Indirect evidence is, so if you see kidney or bladder activity like within 4 hours, that means it's getting into the circulation faster. Again, you should not be like a traumatic lumbar puncture, or tracer should not be kind of infiltrated in the subcutaneous region or beyond the thecal sac. Otherwise, these things could be just because of the tracer, because of that traumatic injection. Okay. So other thing is absent cerebral cortical activity, like the supratentorial activity even at 24 hours, or rapid loss of spinal activity. So these are indirect signs indicating spinal CSF leaks. Of course, disadvantage is, it's a poor spatial resolution study. Another example here, patient with multiple arachnoid herniations, and one of them has ruptured. You can see the contrast kind of leaking into the epidural space and then coming out through the neural foramen there, right? So subsequent CT shows you the contrast kind of leaking through the foraminal region. Okay, so treatment options, we have like conservative, epidural patching, and surgery. This is the most common treatment modality used. Okay, conservative, patients with low suspicion or very less symptoms. So they are kind of advised to have like bed rest, oral hydration, caffeine administration, abdominal binder. Exact duration is not very clear. Some patients, clearly improve with this conservative management itself. Epidural patching is the most common interventional procedure they do. It can be targeted patching or a non-targeted patching. Targeted patching is where like, the level of leak and the autologous blood is injected at that level, so that the effect is much more. Similarly, non-targeted, you don't know the level. So usually suspected leaks are in the thoracolumbar region. So that's where the injections are performed. And mechanism of action is said to be because of the direct tamponade and or decreased thecal compliance and shift the CSF pressure more cranially. Surgery is when like the epidural patching fails, especially for the ventral leaks, the osteophytes are kind of resected. For the arachnoid herniations, they are repaired, and CSF to venous fistulas are also can be clipped. Okay. Same thing with epidural patching, as I said, kind of targeted and non-targeted. So again, like more the number of patching, better the response rate. So 3+ then has more than 50% response rate with the epidural patching. Okay. So SIH diagnosis errors. So these are important to know which level the error can happen in the diagnosis. One is like at the basic level, at the level of history or poor understanding of disease entity. That's where like the errors can happen. The clinician may or may not even suspect like the SIH, right? Or if there is any alternative diagnosis thinking, like headache maybe because of migraine or subarachnoid hemorrhage or meningitis, and you recommend CSF, which can be misleading because these patients tend to have some degree of lymphocytic pleocytosis, mildly increased protein, and or misinterpretation of imaging, especially if say like there is a leak and you localize it to a false level. There is something called as a pseudo leak condition where because of the large epidural fluid, it leaks at the C12 level, which is usually like not the site of leak. It's just like the pseudo leak where the CSF epidural collection is kind of just escaping from the canal. So you don't want to make that area as suspicious for site of leak. Okay, so these are where like the errors can happen. And coming to the algorithm, what we follow at our institute is, so say like there is a clinical suspicion for SIH. First thing we do is MRI brain without and with contrast. So if the signs are negative, like MR brain is completely negative, then depends on what's the degree of clinical suspicion. If the clinical suspicion is low, then it's just clinical follow-up, conservative management. Next, two possibilities, either negative with high suspicion or MR brain positive. In both cases, we tend to proceed with initial screening MRI. If MRI not possible, then we do a CT myelogram, like the regular prone position. In this, depending on the imaging findings, whether there is an epidural collection or no epidural collection, right? So if the epidural collection, then we suspect ventral leaks. So we advise more prone like imaging, problem solving imaging. Either if we have a particular like region of suspicion, we tend to go with the prone dynamic myelogram. If we don't, then we have to cover the entire spine. Then we prefer doing like the prone dynamic CT myelogram. If the epidural collection is negative, if the bud-on branch is positive, then we are suspecting type 2. If that is negative, then we might be looking for a CSF to venous fistula. Both can be seen on decubitus myelograms, either like a direct CT myelogram or a dynamic myelogram. So that's like the algorithm what we follow here. And this is the more latest one in like last year, December edition came out with consensus guidelines like based on imaging like of brain and spine for patients with suspected spontaneous intracranial hypotension. I think that's my last slide, and thank you very much for your attention.